Hi everybody, it's been a little while. I hope everybody's doing well. Welcome back to the channel. My name is Ollie. I am a junior doctor living and working in northeast of England. There's been a lot going on in the last little while, so here is just another summary that we do sometimes just to bring you up to speed with everything that's going on, where I am in my training, what's been happening and what's coming next. So the first thing that I've addressed in the title is that I've got yet another job. We change jobs every 4 months during our foundation years as junior doctors. So if you remember, I qualified as a doctor last July, so it's almost been a year since I started working as a doctor. It seems to have gone by so quickly. I completed my first 4 months of my career working as a doctor in hepatobiliary surgery and transplant. So more generally, that's the general surgery team. That was my first rotation. Then I moved on to an academic medicine block where I spent 4 months doing research with some general medicine on calls. So I still had clinical contact. I was still required to go into work and practice as a doctor, obviously, because these first few years are really important for setting you up as a safe physician later on. And just for reference, because it's kind of important to the job that I'm doing now, general medicine, or kind of general internal medicine, covers the more medical specialties, if you like, so things like cardiology, respiratory medicine, gastroenterology, geriatrics, stroke, neurology, that sort of thing, general internal medicine. And that was actually really helpful when it came to the job that I'm on now. So I've been in this job since the beginning of April, where I'm working as a junior doctor in acute medicine. Now what this is it's very similar to general internal medicine, the job that I was doing before, but as the name suggests, it's much more about acute scenarios, the emergency, the urgent things that need to be fixed then and there to keep people safe. So in my previous job when I was working in general medicine, I might spend one shift on, say, the cardiology ward, where they would have all of their specialist nurses and all of their equipment. I then might do a shift on the stroke ward, where again you would have specialist stroke nurses and stroke physicians and everyone else that was dedicated to stroke. Acute medicine is much more undifferentiated acute care, because ultimately you don't know what's going to come through the door at any given moment. Basically everyone comes in via A&E, so if someone's very unwell or they have a traumatic injury or they have an infection or something like that, they'll present to A&E or be sent there by their GP, their general practitioner, and told to come to hospital. A&E will see them and decide, does this person need to be admitted? Do they need to come into the acute medical unit to be seen in more depth? Or can they go home? Or do they need to go somewhere else? Do they need to have emergency surgery, whatever? So we have ED kind of at the front door as the beginning of what we might call front of house medicine. And then if it's decided that they're unwell enough to need to be potentially admitted and seen by an acute physician, they will come into my acute medical unit where I work along with my colleagues and the dedicated acute nurses and consultants and everyone. And then we will take a much more detailed, full history, full top to toe examination, full set of bloods, and get any sort of specialist investigations that we need, so we can then make a more detailed plan and decide where they're going to go. And as you might imagine, the pace of this job is much more significant than any of the jobs that I've done before. The job is more or less clerking, what we call taking a history, doing an examination, doing all of the investigations that you need to do, back to back to back to back to back as quickly as possible, because you've got people coming in all the time. You've got a steady stream of people that are waiting to be seen, and you've got a team of maybe 5 or 6 doctors that are working as fast as we can to see people as fast as we can and either send them home or get them into a bed or onto a ward and make it so that they're waiting for as little time as possible. Now, of course, this is a balancing act between lots of different things. So I'm still a very, relatively speaking, inexperienced doctor. So I'm at the stage where I still need quite a lot of support, often from the senior doctors. And thankfully what happens, even though the pace is very kind of aggressive and always trying to move forward, what happens is I will see a patient, take a full history, examine them, review the bloods, order any investigations that I might want, an X-ray, a CT scan, anything like that, discuss it with all of the various professionals, and then my plan, what I think should happen to that patient, often which I've had to start, so I might decide they need antibiotics, or they might need this medicine. I will do the basics that I'm able to do within my own scope of practice. Then I will go through the case with either a registrar or a consultant, in short, a much more senior doctor, who can either say, yep, your plan sounds good, do your plan and get back to me when it's been done. Or they might say, you know, did you ask this? Or actually, this medicine might be better in this particular scenario, or we need to add this blood test on, or make sure you get this scan that you didn't request, or something like that. So they can tailor and fine tune your plan and go through everything with you. So there is that support network there. And this is a really important process called a post-take. Often in the morning after a night shift, it will form what's part of a post-take ward round, where a consultant comes in and sees all of the patients that have been admitted by the registrars and the juniors overnight. And there's a really valuable experience in going and seeing like your patient, because you're taking ownership of that patient admission and saying, you know, Dr. X, I did this, this, and this. This is what I found from my history. These are the salient points. Then I did this, this, and this. And my final differential is this. And this is my plan. And because you can lay out your entire thinking process from start to finish in that way, the consultant will very often then give you feedback. It's a very apprenticey type relationship, where again they can say, yep, actually next time you might want to do this differently. And then the plan happens and hopefully all is well, and the patient either gets admitted for a little while or they go to a ward and they go home. And because it's all undifferentiated general acute medicine, you can see a completely wild range of things in each shift. So you might see a heart attack, you know, a STEMI or an NSTEMI. You see a lot of sepsis, a lot of COPD, a lot of asthma, a lot of weird rashes, a lot of things like urinary tract infections, pyelonephritis, sort of weird undifferentiated abdominal pains, gallstones, that type of thing. It really is true generalist medicine, because you don't know what you're going to be dealing with on any shift. So learning loads, the pace is great. I'm actually really enjoying the sort of shorter patient interactions. I know that's maybe a horrible thing to say, but it can be quite demoralizing, I've found, in some settings, if you're working in the same ward for a long time, where you can see people that either take a very long time to get better, or you know are never going to get better and are just there for weeks and weeks and weeks and months. Whereas in some senses, I suppose, in this acute setting, it's I see the patient, I do my bit, and then they either go home or they go to the right person who's going to look after them and provide them more care. You don't have as longitudinal a relationship with patients in acute medicine as maybe some people would like. I think there's a nice balance, because one thing that we are careful to do is to, even once patients have been discharged from our care in the acute unit, is if you've got particularly interesting cases or things where you weren't sure or you want to know what happened, we do follow those cases through and we see what care people have ultimately received if they've had surgery or interventional procedures or long-standing investigations. I think that is something that's really valuable to do as a junior doctor, because obviously you can learn tons. You've done your acute bit, but what actually happens to them long term? And again, this is how you build your generalist medical knowledge. So that's my new job. That's acute medicine, loads of nights, lots of long days, 9 a.m. till 9:30 p.m. So long, difficult days, still often finishing late. I've got another month of this, and then for the final 2 months of F1, I will be going to work on a clinical pharmacology unit. Don't really understand what that is yet, but that's where I'm going to be going. And then the other big thing that's coming up is what's called ARCP. I think it's Annual Review of Competency and Progression or something like that. It's the landmark that decides ultimately whether or not F1 doctors are going to complete FY1, if you like, have met the standards required of the training curriculum and are going to move up to F2 or SHO. So with that comes a pay increase and more responsibility, quite a lot more responsibility. The SHO can be asked to do quite a lot in medicine and surgery. But basically what this measures is, have you been completing a satisfactory portfolio throughout the year? So we have to track the training opportunities that we've been doing, all our own learning, attending teaching, contributing to quality improvement in the trust, and lots of different things. I'll actually go through the portfolio in more detail if that's something that you guys would find interesting. But my internal deadline for ARCP, where the local team are going to start looking through everything, is the 3rd of May or something. And my portfolio is in no way going to be ready by that time, because it relies on a lot of meetings with consultants and people who don't answer emails and don't sign things off when you ask them to. So you just have to go and hunt people down, often in your own time. You can't do it at work often because there's no time to do it, and it's one of the ways in which the foundation program doesn't really work. It relies on a lot of things that are beyond your control and the whims of somebody going out of their way to help you. So it's annoying, but it's one of those things that everyone has to deal with. Then the other major thing that's happened is I got COVID for the first time since the start of the pandemic. I've got all of my lateral flows, all of my collection of them here. Basically, towards the end of my last shift, I became symptomatic. This was like at the very, very end, just before handover. So I put on an FFP3 mask and went home. Then I basically slept all of the next day. And then about 4 o'clock in the morning of the following day, I tested positive on lateral flow, positive for COVID. I'm fully vaccinated, fully boosted, and all the rest of it. The first few days were horrendous, absolutely horrendous. I don't think I really left my bed for 3 days, barely eat or drank anything. Just basically slept for 3 days solid. Not medical advice, but basically subsisted only on Strepsils and Sudafed for a few days. Then was very up and down, getting better. And just with regards to the work situation, our situation at my trust at the moment, I don't know how other trusts are dealing with this. The way it works is you test positive on day 1, if you like, or that's when your isolation period starts. You then don't start any more testing until day 5 of your isolation. Then from day 5, you test every day using the lateral flow cassette. And as soon as you get 2 consecutive negative lateral flow tests, you can go back to work. I can't remember whether your symptoms are important at that time or not. But in my case, as was the case for literally all of my other colleagues that I asked about this, none of us tested negative during the entire isolation period. And again, at least at my trust, you have to complete 10 days of isolation, after which you are free to return to work. So yesterday was day 11 for me, so I was able to go back to work. And there's not too much to dwell on. Obviously, everybody knows what COVID is at this point and what it isn't. I suppose on the one hand, I felt dreadful for the first few days. I was just really, really bad with it. I've still got a sort of post-viral cough, a tickly cough at the back of my throat. It's not too bad at the moment, but it seems to get worse throughout the day. I'm pleased that the sort of fuzzy headedness has gone away as well. I had that for the first few days where I couldn't really string coherent thoughts together or focus on anything for any stretch of time. Thankfully that went away on like day 4. But some people have described that lasting a very long time. So I'm pleased I didn't have that, and I didn't lose my sense of smell or taste either. So that's pretty good. But the other thing to be said is that I felt really, really guilty about not being able to go to work, especially towards the end when I felt more physically well, if you like. I don't know whether I would have been well enough to go to work, but certainly not as bad as the first few days. And because you can see the rota and you know how many people are off at one time and how stressful the job is, especially around bank holidays and things like that. There was real like professional guilt about not being able to go to work. So I was actually really pleased and really ready to go back to work. And then the very, very last thing that I want to talk about, although the video is already too long, so I'm not going to dwell on it, is the BMA elections, the BMA Council, and we won. We did it, guys, we won. I've been elected to BMA UK Council, which is essentially the executive branch for the British Medical Association, which is the largest trade union in the UK for doctors. So I could say council is the branch that sort of oversees the rest of the BMA, and I suppose in some part is responsible for the overall direction that the trade union takes. Although the really important thing to say is that I know that people are wound up, especially about things like industrial action, which is something I'm fully on board with if it comes to it. Like I've said, pay restoration is the thing that I personally am going to be very single-minded about, because I think it's the most important thing facing the profession at the moment. I think we can't really risk diluting our message beyond that too far, because the more things you try to do, the less well you do any of them. So I think we really need to be very single-minded and very bloody-minded about getting pay restoration, or as close to pay restoration as we can. And crucially, not to be worried about the court of public opinion. I think the time for that has long passed. Essentially, there is no other profession that I can think of that relies on the court of public opinion to get paid fairly for the role and responsibility that it does. And I don't think the time is right anymore for doctors to be particularly concerned about that, because certainly for myself now, I think as officially a high-ranking member of the trade union, I'm responsible to the profession, to the members of the BMA, and literally nobody else. And so the things that I say and do have to be in the best interest of the profession. That's the role of a trade union. It's to fight for the best interests of its members. That's it. So that includes all junior doctors, all consultants, and all medical students. And this is the thing that I think we really need to remember. Any reduction in terms that we accept, or anything that we don't achieve to the best of our ability, is essentially making a decision on behalf of the entire profession, either to be paid less or for our conditions to be worse, or whatever you like. And for medical students who can't speak up for themselves really as the members of the professional body yet, we owe it to them particularly, because the decisions we make now and in the next 4 years, for as long as certainly my term is going to last, those decisions are going to affect medical students that are graduating in the next 4 years. We create the terms that they will be subjected to. So we need to get it right. That's where I'm going to wrap this up. If you've got any questions about anything that I've said, videos that you would like to see, I've got some really exciting new sponsorship agreements to share with you guys soon. But I'll wrap the video there. Thank you so much for watching, guys. Take care. I hope you're all doing well and staying safe, and I'll catch you later. Bye.